Thailand. So welcome back to the iAOC lecture series with the collaboration with Indiana University. Today we are going to have the second session on the pediatric neuroimaging. And this is the second year that we have this course, the didactic lectures from Indiana, broadcasting internationally to Thailand and Southeast Asian country. So today we are going to talk about the pediatric leukocoria, what we are looking for. And I have an opportunity to have Dr. Taylor Knight from the Riley Children's Hospital, who is a pediatric ophthalmologist, who very interested in the leukocoria and interested in medical education, going to give us a talk on the clinical presentation and the physical examination that you can see in the pediatric leukocoria and what he needs from us as a radiologist. What can we help them provide a better care for the patient? So welcome, Dr. Knight, Taylor Knight. Yeah.
Thank you so much for that lovely introduction. Like she said, I'm Tyler Knight. I'm an assistant professor here at Indiana University and the director of medical student education. So I'm going to go ahead and get my slides shared here.
Mm-hmm.
Can you see this?
Yes, I can. Mm-hmm.
Excellent. So all of the content here and photos were obtained from de-identified patients from Indiana University Health, and a few sources cited provided some photos as well. This is for educational use only. I have no relevant financial disclosures. So by definition, leukocoria comes from Greek origin and literally translates to white pupil. It is described as a reflection of white light seen on direct illumination of the fundus through the pupil. You can also kind of have a pseudo-leukocoria where there is a cataract or a corneal opacity that fills the pupil, but that should easily be teased out on examination where that opacity is. All infants should be screened in the first 2 months of life, and the American Academy of Pediatrics recommends doing this examination in a darkened room with both eyes open, using the direct ophthalmoscope approximately an arm's length away from the infant's eyes. Ideally, you know, the infant's eyes can be forced open, but if the infant is just kind of looking at you and keeping both eyes open, that allows for the best and easiest examination. The red reflex of both eyes should be symmetric. So dark spots in a red reflex, a blunted red reflex on one side, a complete lack of red reflex, or white reflex are all indications for referral to an ophthalmologist. The differential, I kind of alluded to this, opacification of the media. I like to clump things into big categories. And you know, there are different reasons for a cataract in a young age. And then, you know, many different reasons for retinal detachment. So we'll go through a lot of these in more detail. Optic nerve and retinal pathology can cause a white reflex, and then many neoplastic processes can cause this reflex. So jumping right in, congenital and early onset cataract is one of the most common things we see for this referral. About 3 to 4 in every 10,000 live births. Most are not associated with a syndrome or a cause. And bilateral cataracts can be secondary to metabolic, genetic, syndromic, or infectious etiologies. And if there's no clear family history in bilateral cataracts, a thorough pediatric examination and developmental examination should be performed. Oftentimes we also get torch titers, VDRL, calcium, phosphorus levels to do a systemic workup for bilateral cataracts. Unilateral cataracts are more likely going to be secondary to local dysgenesis, so persistent fetal vasculature, formerly PHPV, which we'll talk about in more detail. Posterior lenticonus is a outpouching or weakening of the posterior lens capsule. That can rupture or tear, and then the lens tissue can become hydrated, and the cataract can quickly progress to a complete white cataract. And then microphthalmia is associated with many dysgenic features within the eye, coloboma, cataract, microcornea. And then trauma, you should always consider trauma in a differential. It can cause a white cataract. So if there's other findings consistent with trauma, there should either be a story that explains the trauma or non-accidental trauma should be suspected. So here's some photos of early onset and congenital cataract. On the left of the screen here are photos from an article cited anterior and posterior polar cataracts, usually small, not visually significant, but may progress, especially posterior cataracts, may progress over time and cause deprivational amblyopia, which again, another topic that we can get into in more detail. But amblyopia is when the brain has a preference for the eye that has a clear media, or it can be bilateral. So if both eyes are affected with cataract, the brain can never develop good vision. So we have to clear the visual axis and allow one or both eyes to start to develop better vision. A few other types of early onset cataract over here. And then these are some of my patients on the right. This patient has a cortical wedge cataract that is not yet visually significant, and I'm just monitoring this patient. But these patients absolutely have high risk of deprivational amblyopia. This is a patient with persistent fetal vasculature. You can see kind of this stalk inserting on the posterior aspect of the lens. And if you look closely here, you can still see some patent arteries. So blood vessels that should have regressed, but did not. And then this is a case of a traumatic cataract. This is an older child, but some of the features are just so classic for trauma, they cannot be missed. And if there's no good story, again, non-accidental trauma should be suspected in these kiddos. But there's anterior capsular pigmentation from the iris here. I don't know, can you see my cursor, my mouse?
Yes, we can.
And then posterior synechii, so scarring of the iris tissue to the lens. And then over here, some iridodialysis, where the iris root has ripped off from the angle structures, and you can even see the white lens here. And on the eye examination under anesthesia, I could see the zonular fibers here suspending that lens into place. So these are findings consistent with trauma. And this kid did have a reason for the trauma, but really good photo.
I think your mic is muted.
Thank you. Persistent fetal vasculature, formerly persistent hyperplastic primary vitreous. I alluded to this and showed the cataract of the kiddo on the last slide. It's usually present in the first 1 to 2 weeks of life and is a failure of fetal blood vessels to regress within the eye. It has a few subtypes. There can kind of be a combined subtype where they have features of both. Anterior subtype has a little bit better prognosis just because posterior subtype can be associated with retinal folds, retinal dysplasia, or detachment, as well as optic nerve dysplasia. I think my spacebar is not advancing anymore. It's muting me, so I'm going to stop doing that. There we go. So again, that photo of the cataract, and then, excuse me, these are the photos of that stalk that we talked about. So it physically connects the optic nerve to the posterior lens capsule. This one is a little bit more faint to see, but it does come to the back of the lens capsule here, and on that, this is the same patient above and below here. And you can see hemorrhages and the stalk inserting on the posterior aspect of the lens. B-scan ultrasound, so in the office or in the operating room at the time of the eye examination under anesthesia, we often employ ultrasonography to look at the structures within the eye. A foci of calcification is present in over 90% of cases of retinoblastoma, which makes seeing calcification dramatically increases your suspicion of malignancy. But if you use the B-scan and you see a fibrovascular stalk that fits, so this is the globe here, and this dark shadowing here is the optic nerve connecting the eye and the brain, and this hyperechoic bright area on the ultrasound that physically attaches to the optic nerve and comes all the way to the back surface of the lens is the stalk. This can also, when it looks thick like it does here, this can also be a complete funnel retinal detachment where the retina has detached from the inside of the globe and is in this funnel formation. So that also sometimes needs to be teased out with the assistance of a surgical retina specialist. Doppler ultrasonography. So if you turn on the Doppler here, and you see jets of red and blue denoting the flow of blood through this is diagnostic of posterior or persistent fetal vasculature. So that kind of concludes the media opacity differential diagnosis. Moving on to different things that can cause a retinal detachment. So Coates disease is classically taught as a unilateral telangiectatic retinal vascular disease affecting young males. Females can be affected and it can be bilateral, but this is the classic teaching. The leukocoria results from exudative retinal detachment. And you even in quiescent disease, you can see discoid glial scarring, subretinal neovascularization, and crystalline deposits. So the leukocoria doesn't necessarily go away even in treated disease. Fluorescein angiography can be very helpful in assisting or clinching the diagnosis, and it also helps to target the treatment. And I'll show you the area that we treat on the next slide. Treatment consists of laser photocoagulation or cryotherapy, and then if we have a exudative or if we have an exudative retinal detachment that is non-resolving, vitreoretinal surgery can be considered. There's some promise for anti-VEGF therapy, but the safety profile in children is unclear. Systemic absorption through the eye and effect on kidneys and brain is not known. And then intravitreal steroids, triamcinolone, can also reduce the exudation, but has risks of cataract and glaucoma. Enucleation is really reserved for kids who either have a blind and painful eye or where a diagnosis of retinoblastoma cannot be excluded. So here are some photos. On the left of the screen is from the classification and management of Coates disease Proctor lecture, Jerry and Carol Shields et al. So this photo actually looks strikingly similar to a patient I saw in clinic, and I was able to get iPhone fundus photos of his more severely affected right eye. But if you look at the reflex on his left eye, part of the pupil has that normal red reflex, and part of it has a more white reflex. And when I looked in the fellow eye, the nerve and macula looked healthy, but on eye examination under anesthesia, he did have exudation in his left eye too. So he was a bilateral case. We treat these little terminal bulbs here where we're tortuous and dilated and abnormal. These are the leaky blood vessels that cause this massive exudation here. And if it presents late, it can present with a total exudative retinal detachment or a complete cataract and retinal and angle closure glaucoma and retinal detachment beyond that cataract on ultrasound. Here are a couple quiescent photos that show you that discoid glial scarring. And again, you can imagine that this could still cause leukocoria even after it's been treated. So jumping right in, ROP is a leading cause of pediatric blindness. It's a abnormal retinal vascularization in preterm infants that causes classically tractional retinal detachment, but it can cause an exudative detachment as well. So there's kind of three epidemics of blindness associated with ROP. The first one was in the 1940s and 50s when unmonitored supplemental oxygen caused poorer outcomes in terms of babies' eyes and their vision. And then advances in neonatal care in the 70s led to increased survival of severely preterm and extremely low birth weight infants. So, nowadays we're talking our 23 to 26 week premature infants that are, 400 to 650 grams on their birth weight. Those babies are at incredibly high risk of developing type 1 or threshold treatment requiring ROP. And it's interesting, but early on in the disease course, oxygen is bad and causes worse outcomes. But later on in their course, when they're older than 32 weeks, sometimes we can even use supplemental oxygen to kind of lower the anti-VEGF drive in these infants. And their blood vessels can continue to grow normally without meeting treatment criteria. But in patients that need treatment, we use anti-VEGF injections and laser photocoagulation. And then if patients detach, despite treatment or have a delayed presentation or just a very aggressive course, they may require vitreoretinal surgery to repair the detachment. Here's some photos of retinopathy of prematurity. The most striking one, I think, is here in the center. The dilation and tortuosity of these blood vessels is pronounced, and the demarcation between vascularized retina and avascular retina is obvious. This would require treatment just with how posterior the disease is, and this is called plus disease, when these blood vessels leaving the optic disc are so tortuous and dilated that kind of tells us that a retinal detachment is impending. And then this patient has grown a little bit further out and does not have that dilation and tortuosity at the posterior pole, but over here you see the junction between vascular and avascular retina. There's kind of this ridge of tissue and there's a red hue to it. Those blood vessels are creeping up onto the ridge. And growing kind of a scaffold into the vitreous. And that is how these babies develop a tractional retinal detachment. And so this, all of these photos would require treatment. This photo shows the macular dragging that is classic in retinopathy of prematurity. And this is just a normal fundus photo for your reference. Bottom right, we have a fluorescein angiography, so dye test that helps look at the vascularization of the retina. And this leading edge is a little bit leaky. It's a little it's less clear and a little fuzzy. And if you watch this over time, it would only get brighter and brighter. So there's kind of leakage of those abnormal blood vessels on the ridge. Familial exudative vitreoretinopathy is, it essentially looks like ROP, but there's no history of prematurity. It's an inherited condition of abnormal peripheral vascularization, and it's carried in just about every fashion. Autosomal dominant is the most common, but it can be autosomal recessive or X-linked. And there have been about mutations in about 11 genes that have been associated with fever. The clinical features and stage you can see on the right there. Stage 1, we just monitor. Stage 2, we use laser photocoagulation to the avascular retina. And stage 3 or more, we need surgery to address. Other causes of retinal detachment. So Stickler syndrome is a connective tissue disorder characterized by high myopia and retinal detachment. So in these kids usually are a little bit older than the infantile or toddler leukocoria that get us worried about retinoblastoma. But they have about a 50% chance of retinal detachment in their lifetime. Usually it happens before the 3rd decade of life, but we've had kids, as early as 3 who developed a retinal detachment. And so we can use laser prophylaxis to try to prevent retinal detachment in these kids. Incontinentia pigmenti is another abnormal peripheral retinal disease, but is also, it's very different. It's characterized with classic skin findings and seizures. And then anytime we've done intraocular surgery, cataract surgery, glaucoma surgery, open globe repair, that does increase the risk of retinal detachment. So if there's any history of that or any obvious findings on our examination, we may not need to go down a path of investigating why we developed a retinal detachment, but we still need to treat it. And then again, trauma, if there's other signs of trauma, and not a great history, non-accidental trauma should be suspected in a retinal detachment. Getting into the posterior examination of the eye, the optic nerve and retinal manifestations that can, or conditions that can cause leukocoria, posterior uveitis and classically toxocariasis is one of the most common things we see that can cause this. It's an infection by a nematode, a roundworm, toxocara, and there's, forms that have hosts in dogs and cats. So, exposure to puppies or kittens, eating, dirt or clay, geophagia, so young age are risk factors for developing this infection. Typically, children present at around 8 years old, but may be infected, earlier than this. And 90% of the time, they have a retinal granuloma with overlying vitritis. They may have a chronic endophthalmitis, but the most classic thing that we see is that retinal granuloma. And we treat it with anti-inflammatories, sometimes antiparasitics. The blood-ocular barrier can sometimes be difficult to penetrate with the antiparasitics. And so oftentimes if they have persistent vitritis or a vitreous hemorrhage, and we're concerned about amblyopia, there's that word again. So, if they're younger than 7 and they don't have a clear visual axis, we need to clear that visual axis so that that eye and that brain can develop vision on that side. So this over here on the left of the screen is an active patient. You can see this retinal granuloma here. You can't quite make out the details of the nerve. There's inflammation and inflammatory cells floating in the vitreous, so that's classic. And then these are all burnt out old macular scars, chorioretinal scars, in cases that previously had an infection. Morning glory optic nerve is a rare congenital malformation. It's a conical excavation filled with glial tissue. So it's this deep excavated optic nerve with an increased number of straight retinal vessels exiting the nerve. So it's named for its resemblance to the morning glory flower. It can be associated with transsphenoidal basal encephalocele, and that's usually seen in kids with dysmorphic facial features, callosal agenesis, dilation of the lateral ventricles. This is not something we commonly see, but we do ask our neuroradiologists to look for certain things. Hypoplasia of the cerebral arteries, moya-moya syndrome, which classically has kind of a smokestack appearance on MRA or diagnostic angiogram. And that is something that puts a child at risk for stroke and something that we definitely want to look for when we see morning glory. Can also be associated with face syndrome, so posterior fossa malformations, facial hemangiomas, arterial abnormalities, cardiac abnormalities, and eye anomalies, and NF2 as well. So here's a photo from the source listed here. You can see the excavation here. This is a 2-dimensional photo, but if you had a 3-dimensional view to this, this would look deep and excavated, like you're looking down a hole. And then all these straight branching retinal arteries and veins. And if you look at the flower side by side, you can see why they named it that. There's this deep kind of hole with all these straight lines emanating from it. And so that's a great photo of the morning glory nerve. Myelinated nerve fiber layer is something that is usually present at birth, non-progressive, and more commonly unilateral compared to bilateral. It's purely just a process where myelination extends beyond the lamina curvosa. It's not malignant or progressive, and really it just causes a relative scotoma in the area of myelination. So if we did formal perimetry, a visual field test, we would probably just have an enlarged blind spot because the optic nerve causes a physiologic blind spot on our visual field testing. And so it would probably just be a little bit larger than normal. So here are a few photos of, and really this, you know, might cause leukocoria if you get it just right and the nerve is, the patient's looking off to one side, or the patient's moving and really squirmy. But if you have something like this, you know, that is really impressive, and that would absolutely cause leukocoria, and probably, you know, with the extent of macular involvement, this would probably cause some degree of amblyopia or a large visual field deficit in this kiddo. Uveal coloboma. So coloboma results from failure or incomplete closure of the embryonic fissure. So the eye begins to form as from an evagination of the diencephalon, the brain tissue, and there's an optic stalk. So put a picture of a snail up here because this is kind of how I think of it. There's a stalk that becomes the optic nerve and the optic vesicle, which in addition with a few other cell layers and migrating neural crest cells becomes the globe, the eye, and all of the ocular tissues. And when it doesn't zip closed all the way, you get a coloboma. And so coloboma is associated with numerous syndromic and chromosomal abnormalities, retinal detachment and cataract are also common in this condition, but the coloboma just appears as a stark area of whitening, often with pigment surrounding it. So here are a few photos of uveal coloboma. So oftentimes they have an iris coloboma inferonasally, and it is and it connects posteriorly. Sometimes it encompasses the nerve and macula. So on the right of the screen here, I would expect that this patient likely has worse vision than this patient who just has inferior chorioretinal coloboma here that does not encompass the nerve and does not touch the macula. So that kind of concludes the conditions that can cause leukocoria from optic nerve and retinal pathology. And so now we're getting into neoplasms, benign and malignant. So astrocytoma or astrocytic retinal hamartoma is a benign glial cell tumor, most commonly associated with tuberous sclerosis, but can be associated with a few other conditions. It usually is asymptomatic and small and non-progressive, and all that's required is periodic monitoring. But if it's involving the macula, the optic nerve, or if it bleeds or leaks, then it's likely to be symptomatic or affect vision, and those patients are more likely to present for treatment. We have a few different treatments that we can use for the tumors themselves or for complications. The article on the left of the screen here is an older child who presented with a exudative retinal detachment here. B-scan ultrasonography shows the lesion here and the retinal detachment. And then the fellow eye had a few other benign masses in the periphery. And again, ultrasound. So the dark space here is the globe. The shadowing here is the optic nerve. The mass is here. It's not super clearly defined, but as you hit, so this is an A scan down here, and that kind of also tells us more information about the density within this lesion. So you can do a B scan with an A scan overlaying the A scan. And then this is one of our patients here on the right with a nerve encompassing retinal astrocytic hamartoma. This patient had tuberous sclerosis. Medulloepithelioma. So this is an embryonal neuroectoderm derived tumor that affects primarily the non-pigmented ciliary epithelium, but can also be primary central nervous system, and can also affect the orbit, but predominantly is within the eye, affecting the ciliary body. It's the second most common intraocular tumor and is usually sporadic. It can be associated with this syndrome, the kind of Dicer1 mutations, and usually presents a little bit older than our, cataracts and retinoblastoma kiddos. You can treat these locally with cryotherapy, radiotherapy, and chemotherapy, but oftentimes it requires local resection or enucleation, or if it extends outside the globe, exenteration. So basically removal of the globe and tissues around the eye to debulk as much of the cancer as possible. Mortality is associated with malignant tumors that have evidence of extraocular extension. So those kiddos do have a poor prognosis. Wasn't able to find any, I know we have a few patients at Indiana University where we've treated for this, but I wasn't able to find any of the photos. So all of these photos come from Intraocular Tumors textbook, and you can see how clearly different they are from everything I've shown previously. It looks like a tumor. It's just behind the iris tissue here. There's blood vessels and kind of sometimes cysts or cavities. And you can also see changes to the iris pigmentation, and you can see the ciliary body being pulled in one direction. So very, very different from everything we've shown before. So retinoblastoma, I wish I had, an entire hour just to dedicate to this, but this is the most common intraocular malignancy we see. 60% of the time it's unilateral, 40% of the time it's bilateral. The bilateral kids are presumed to have a germline mutation, but about 15% of unilateral cases do carry the mutation. Genetic testing for RB1 mutations is recommended in everybody, if possible. That helps guide both prognosis of disease and how closely we monitor not just the affected eye in unilateral cases, but the unaffected eye for new tumor development over time. The RB1 is a tumor suppressor gene on chromosome 13, and germline cases are at risk for trilateral retinoblastoma, which I believe we'll get into in a little bit more detail here soon. But that is a primitive neuroectodermal tumor in the brain, pinealoblastoma. Treatment goals in this order are to preserve the patient's life because it's, malignant tumor, preserve the eye tissue itself, keep the eye comfortable and in the eye socket, and then to work on vision last. So it's really important that we do those things in that order. So eye examination under anesthesia is really crucial in this because to look for peripheral tumors, we have to do a scleral depressed eye exam, and no child is going to tolerate that in the clinic. The eyes need to be widely dilated with good illumination, and we have to look all the way to the ora serrata, the anterior retina, looking for tumors. B-scan, ultrasonography, and fluorescein angiography can be helpful in clinching the diagnosis. Like I mentioned previously, if we see calcification on the ultrasound, it's almost diagnostic. And fluorescein angiography, in cases where there's a large detachment and you're not sure if it's really bad exudative detachment from Coates disease or if there's a mass. The B-scan should show you a mass with calcifications as well as the exudative detachment, and fluorescein angiography would maybe just show the terminal bulbs, the telangiectasias with leakage on a bad exudative Coates case. You want to avoid CT scan if possible, especially in germline cases, because it exposes them to unnecessary radiation and increases the risk of secondary tumor formation. The treatment for this has really expanded in the last few decades. We have multiple chemotherapeutic options, both the drugs of choice as well as the mechanisms to deliver them. In kids that have bilateral disease, oftentimes we use systemic chemotherapy. We can use intra-arterial chemotherapy where we cannulize the ophthalmic artery, usually using femoral artery access. Neurointerventional radiology is obviously helping us with this, but we inject chemotherapy directly to the eye tissue with intra-arterial chemotherapy. And then for cases that have vitreous seeding, the tumor has grown and sometimes grown into the vitreous or or vitreous seeds of tumor growth into the vitreous can respond to intravitreal antibiotic injection. We can do local destruction, usually for smaller or newer tumors that either pop up in, while the patient is undergoing chemotherapy. If a large tumor has kind of a secondary growth off to the side, or a completely new tumor growth somewhere else, if it's small enough, we can treat it with cryotherapy or laser photocoagulation. Large tumors that are non-responsive to chemotherapy or non-responsive we can use radiation, either external beam or plaque brachytherapy, where a radioactive plaque is placed on the sclera just adjacent to the tumor, and we confirm its placement with ultrasound and other imaging techniques to ensure that the plaque is in the right place and that it will treat the tumor appropriately. And then enucleation. So, in kids with extensive tumor burden, group D or group E disease, where it's already invading the anterior chamber, or you have high suspicion that it's there's a risk for metastasis, then enucleation is the best thing to do. And whenever you do the surgery, you want to get as much of the optic nerve as possible to help reduce the risk of metastasis and help with your pathologic examination. Extensive choroidal invasion, optic nerve invasion past the lamina curvosa, and anterior segment invasion are all poor prognostic factors, and the kiddo may benefit from post-surgery chemotherapy in those cases. So here's some photos. You can see a large untreated tumor here, and quiescent or treated disease with kind of the calcified appearance to these tumors. This here is a complete exudative retinal detachment, kind of a funnel formation. You can see this slit here. So that's the optic nerve is connected in the back, but the retina is detached everywhere else. And on ultrasound, I think this ultrasound is actually for this photo over here, but you can again see the kind of the globe here, the optic nerve shadow here, and then this large mass here. So I'm going to move my Teams window here, and then the focal areas of calcification here, here, here. So these tumors grow so quickly that they often outgrow their blood supply, and they undergo autonecrosis and then calcification. And so that's why we see these bits of calcium within the tumor bed in retinoblastoma. So that brings me to the end of my content here. I'm happy to take any questions.
Thank you so much, Taylor, for the excellent lectures, and give us more detail on the fundoscopic exam and what you see on the physical examination of the patients. Any questions from our trainee or audience at IU? I loved on your lectures on the retinoblastoma that you said no CT. I love that, because we don't want to do the CT on the patient that young.
Yeah, both for just the age of the kid and exposure to radiation, but also, especially in these kiddos with germline cases, you increase the risk of secondary tumor formation. So, I think it's worth the sedation. It's worth the extra time under anesthesia to get the good quality MRI images.
Agreed.
Hey, Dr. Knight, I had a quick question. Do you ever give a differential for these on fundoscopic exam, or is it pretty obvious when you're using the slit lamp to kind of know, what this kid may have?
Yeah, it's usually pretty obvious, but sometimes, from birth to 2.5, 3 years can be a really tricky eye exam in the clinic, just depending on, what mood the kid is in that day, how cooperative we are at baseline, how angry we are after somebody put in the drops. And so, if we're ever, struggling to get what we need in clinic, oftentimes we just try to get an eye examination under anesthesia as quick as we can to confirm the diagnosis one way or the other. And then, as you can see, the fluorescein angiography, the ultrasound, taking fundus photos. And then, once you have the eye examination under anesthesia, these all look pretty different. But yeah, seeing a squirmy kid in the clinic, you might not be sure right away.
Wonderful. Thank you.
So maybe this is a super silly question, but is there ever any role for like tissue sampling? I know, I know very little about ophthalmology.
Great. So if you're suspecting retinoblastoma and you just can't rule it out, and you're worried enough about it, I would not get a tissue sample, and instead I would do an enucleation. If you imagine doing like a fine needle aspiration or a biopsy of this tissue, and then those tumor cells get onto the sclera or onto the conjunctiva, then they can get into the orbit, then they can metastasize, and then the game is over. So if retinoblastoma is even kind of in the corner of the back of your mind, I would not do a tissue biopsy. I would remove the eye and say, life comes first, because that paradigm that we talked about, treatment, we're talking life first, then we're going to try to save the eye, then we're going to try to save vision. So if it's in the differential, I would probably do the enucleation and have the pathologist tell me for sure.
Cool, thank you.
So I believe that you don't send every patient with a leukocoria to the MRI scan, right? So what is
Correct.
I would say like a majority of the leukocoria patients, you are able to give diagnosis based on the fundoscopic exam, right? So what kind of patients that you're going to send it to us?
I think, I think we would often send, all retinoblastoma cases, cases where we have diagnostic uncertainty, and then some of these syndromic things like morning glory, nerve, incontinentia pigmenti, some of these things that have associated CNS findings, or we're just, we're not sure. I think the imaging can help push us one way or the other. If we're trying to figure out, is it exudative coats? Is it retinoblastoma? Are we going to do an eye examination under anesthesia anyways? And we're going to need, images. Can we coordinate that anesthesia to lump it for the kiddo so we're not getting multiple general anesthesias back to back? Sometimes we try to do things like that.
That makes sense. Yeah. More questions?
Yes, hi. Ty, can you hear me okay?
Yes, I can.
Okay. Hi, Tyler. Thanks. Great for a great lecture. This is Isaac. I'm one of the staff on pediatric neuroradiology. And my question is about child abuse. So unfortunately, as you know, in Raleigh, we have too many child abuse cases or allergic child abuse cases. The imaging finding a lot of time is not all that pathognomonic. So one thing is that we always sort of, obviously, clinical context is extremely important for correlate with our imaging finding. So about the clinical findings, specifically about retinal hemorrhage, I always was told that that's one of the most specific or highly suspicious sign. Is there a particular gradient, or how much retinal hemorrhage is considered suspicious, or any retinal hemorrhage is considered suspicious?
Any retinal hemorrhage makes us suspicious of trauma. It's a really tough thing to sort out, because if a kiddo, a child or an infant has 4 or 5 hemorrhages in one eye right around the optic nerve, and maybe they fell from mom or dad's shoulders, for example, and that's honest. It's tough to say, you know, accidental trauma can definitely cause that, and then but non-accidental trauma is usually too numerous to count. Retinal hemorrhages in every layer, so pre-retinal, intraretinal, subretinal hemorrhages. If there's schisis, if there's splitting of the retina, or detachment, or you know, there's a couple findings where it's, you know, I just look at it and I say that looks like child abuse, that looks like non-accidental trauma. You know, obviously there are other things in the differential, but there's ones where you just look at it and you say, I think, you know, I think we all know what happened here.
Gotcha. Okay, great. Thank you so much.
Wow, thank you so much. So Tyler, are you going to stay here until the end of my talk, or are you leaving
Yes.
now?
Yeah.
Okay, sure. Because I think I might have like a couple questions after my talk, because I want some clarifications on the morning glory disc and coloboma also.
Absolutely.
Yes. Okay. So we're gonna switch back to my talk that has a lot of images related to leukocoria. Share my screen. This one. Can you see my screen? Okay. So we are going to switch gear and talking about the imaging findings for the pediatric leukocoria. So the outline today that I'm going to talk is how we optimize the protocol and sequence to give the correct diagnosis for the pediatric leukocoria. And we're going to describe more on imaging findings on the normal growth anatomy. And we are going to talk about the difference between retinal and choroidal detachment, as Dr. Knight mentioned about the retinal detachment a lot. And then we're going to talk about the imaging checklist and on each diagnosis for the tumor, retinoblastoma, or like a retinal astrocytic hamartoma or medulloepithelioma. After retinal detachment for the cold disease, retinopathy of prematurity, and also the medial opacification like a PHPV. And then we are going to talk about the optic nerve, morning glory disc, and coloboma. So how about the protocol and sequence? So what do we have in our hands? So normally we have CT and MRI, and majority of the ultrasound has been done by ophthalmologists, right? So MRI give us the better imaging resolution and provide the important role as for the workup, differential diagnosis, and treatment planning. And as Dr. Knight mentioned earlier, that they are trying to avoid CT, so because of the radiation risk, and even the CT can give you the better detail on calcification, but ultrasound can tell the calcification also, and MRI can tell you the calcification. So which means the CT probably not that very useful in this setting. So when we do the protocol, when we have the patient with leukocoria, so what should we do? Instead of just doing the MRI orbits only, we should do brain and orbits protocol. The reason is because we want to look for any intracranial metastasis if there are suspicions for retinoblastoma or medulloepithelioma. And we also want to look for any associated findings in the brain in some diagnosis, like retinal astrocytic hamartoma that usually related to has an association with tuberous sclerosis or NF1, or the patient with a retinopathy of prematurity that has like a sequelae of prematurity, like a periventricular cystic leukoencephalomalacia or hemorrhage. So in terms of the standard MRI orbit sequence, so normally on the standard routine that you normally see on adult side, they have like an axial and coronal T1 spin echo or 2D image. that we use that thing for checking for hemorrhage or the proteinaceous material. We also have the axial and coronal T2 2D image that we can see the detail of the group size and any findings in the group. We also have the GRE or SWI that we can use for the hemosiderin position and also calcification. And normally we have the DWI, which is a DWI of the brain that we can see the tumor grading if the patient has retinoblastoma. So my suggestion for the adding sequence for the ORBITS protocol in children that suspicious for leukocoria or retinoblastoma is we need a high resolution T2 3D image. So when we have the high resolution T2 3D image, we can see the better detail of the retina, of the optic nerve, and we can have like a very thin cut, less than 1 millimeter. Normally at Riley, we go down to like a 0.5 millimeter. So by this way, if there's suspicions for retinoblastoma, we can see like additional lesions in the same side or like a contralateral side of the group. So by this way, it's gonna give you the better detail on the additional foci. And I also recommend to have like maybe like a small field of view of the SWI for the checking of the hemorrhage and calcification. And on top of that, when you see any mass or anything, or if you have any like a lump, or if you have a suspicion for intraocular mass, I think one thing that we should do is if we have the suspicions for tumor, we should do the DWI images, because on the DWI images, we can tell this is high grade or low grade tumor. So by this way, if you can do like a more thin cut and detail at the orbits for the DWI, it will give you the better idea of the tumor grading. So in terms of the anatomy of the group, on the axial T1, there are three things that I want to point it to you, so you can see this thing better. So when you look on the layer of the group, so the first layer, the most inner layer that you can see hypo on T1, that is the retina layer. And then next to the retina, that is a colloid layer, which is relatively hyper, like a T1 hyper intense. And then the most external layer is a sclera that dark, again like a T1 hypo. So it looks like a sandwich in this area that normally you see like a dark retina, bright colloid, and dark sclera on the T1 image. And this is on the T2 3D image that you can see detail of the lens better, ciliary body and posterior group, and also the optic nerve. And on the T2 3D, we can has like the reformats and also the thin cut, like a 0.5 millimeter thickness to see details better. And then we are going to switch gear talking about the retinal detachment and choroidal detachment. How can we differentiate those two things? So this is the drawing images from StatDX. So for the retinal detachment, we know that the classic imaging for the retinal detachment is a V shape and has the apex at the optic disc like this one. So you have like some fluid stuff in the retina in the posterior group, and you have you see the line that has the V-shaped attachment at the optic disc, compared to the choroidal detachment that usually parallel to the group and does not cover the optic disc. So for the imaging checklist, when the ophthalmologist send the patients to us with the indication of leukocoria, so you need to rule out retinoblastoma until proof otherwise, because that is about 60% of the patient that has present with the leukocoria. And then the next thing is you need to check at the group size, if it's a big, small, or it has some deformity. So when we're talking about a size of the group, so when you have a normal size or larger size, a little bit larger size of the group, differential diagnosis can be retinoblastoma or cold disease. For the small or a deformity of the group, it can be a retinopathy or prematurity or PHPV. And then you check if the patient has a retinal detachment or any hemorrhage. And then this is the most important thing, is you need to check if the patient has underlying mass or not. Because when the patient has underlying mass, that's likely to be retinoblastoma, that you need to check for calcification and also restricted diffusion. So this is the first case that I have, and you can see the image quality is not that good. This is a CT scan, non-contrast. So this is like a very old study, like maybe 15 years ago, 3 years old with a left leukocoria and has a preseptal soft tissue swelling. So on this image, first thing that you can see here is on the left group. It's a little bit too big compared to the right and has a hyperdensity content within the group with calcification. And you can also see the abnormal signal intensity or abnormal density along the left optic nerve. And the left optic nerve is a little bit too big. So this patient has the follow-up MRI after that confirmed the same finding, that a big left group with internal content that shows some calcification here, and also have enlargement with enhancement of the optic nerve, left optic nerve, and also has some intraocular or intracorneal fat involvement. And when you look on the enhancing mass in the left group, that mass show restricted diffusion. And when you look back to the optic nerve, there is also restricted diffusion in the optic nerve. So this is the patient with retinoblastoma. So as Dr. Knight mentioned earlier about neuroblastoma, one thing that I want to point here is this is a disease that exclusively for the pediatric age group. So which means the mean age is around 18 months and usually present before 5 years old. And I mean, our job responsibility as a radiologist, besides detect retinoblastoma, we also need to check for any additional lesions like a trilateral or quadrilateral in the pineal area or suprasellar area. So we need to check for any extraocular extension, which can tell you the poor prognosis, and also metastasis to the optic nerve. On the CT, calcification, as Dr. Knight mentioned earlier, and the MRI, there are 3 things. So intraocular extension, extraocular extension to the optic nerve, and intracranial extension that we need to check every time for the retinoblastoma. So the key imaging on the MRI is, I love DWI. When you see any mass or any lump or any lesions, you should have a DWI to tell you if there is any restricted diffusion or not, to suggest high-grade tumor. I like T2 3D to look for any additional lesions on the same side or contralateral lesions. And also I need to look on the post-contrast brain for the additional lesions in the pineal or sellar area. Okay, so it's gonna be a little bit more interactive. I need my help from my fellow. So I have 4 questions for 1 question for each fellow. So who want to take this one?
Hey, this is Abdul. Good morning. Yeah, I can take this
Good
one.
morning. Yes, please, Abdul.
Okay, so we see that there is so we have on the left side of the screen, we have axial T2, and in the middle we have T1 post contrast, and then we have ADC map on the right of the screen. We see that on the left upper image, we see there's a T2 low T2 hyperintensity lesion along the posterior wall of the right and left lobe. In the right side, it looks like it's at the level of the optic nerve insertion to the globe, and in the left a little bit to the temporal side. It looks like it's homogeneously low T2, showed some post-contrast enhancement, and it looks like it's demonstrating diffusion restriction as well. So I mean, it's too small to determine if there's any calcification within the lesion, or any central necrosis or hemorrhage. I would say for the differential with this 2-year-old boy, could be bilateral retinoblastoma or melanoma.
Oh, that is the correct answer. So we see so the patient present with right leukocoria. You cannot only look on the right group. You need to look like a bilateral. And in this patient, turn out to have a bilateral retinoblastoma. So I think the key thing is even you don't see the calcification very well and you don't see the retinal detachment. In this patient, it's a soft tissue lesions that show restricted diffusion. So that is like a retinoblastoma until proof otherwise.
Cool.
Good job. Yep.
Thank you.
Okay, so right now our current protocol besides CME brain and orbits, we also add the MRA brain for the to check for the origin of the ophthalmic arteries, because if the patient need to do like the emboli the chemotherapy, intraarterial chemotherapy, it's gonna reduce time for the neuro interventionist to find the origin of the ophthalmic artery. So it's gonna reduce radiation dose, and they can plan properly for the treatment. So this is the third case that we have here, 19-month-old boy with the right esotropia, ptosis, orbital cellulitis. And they mentioned that patient has a prior history of the retinal mass. So on this image, you can see this is a T2 3D that you can see the plaque-like lesions, T2 hypointensity in the right optic disc, maybe a little bit T1 bright, and restricted diffusion or not, I'm not sure. I cannot see it very well, but maybe mild or no restricted diffusion, but no definite contrast enhancement. So in this case, I think it's very difficult to differentiate if this is like a retinoblastoma or not, because the lesion is too small. We cannot see the restricted diffusion very well, and we cannot see the enhancement very well. But I think, as I mentioned on the first slide, when you see leukocoria, you need to rule out retinoblastoma until proof otherwise. So this is the patient that I want to show you the diagnosis of the hamartoma of the retina, which is very difficult to differentiate from the retinoblastoma. And I would say this is the only patient that we have in our system that has a path-proven hamartoma of the retina. When I do search from the pathology report back for 20 years, this is the only patient that we have in our system. So is that not that common? But when you see this thing, one thing that can help you differentiate this thing from the retinoblastoma is if you have any other associated finding within the brain that suggests of tuberous sclerosis or NF1, because tuberous sclerosis, 50% of tuberous sclerosis develop this hamartoma, and 25% has a bilateral. So I think like the key MRI findings, these lesions can be calcification, but it's probably not that common. No necrosis, no hemorrhage, and growth is not significantly growth towards the vitreous humor. So which means this can help differentiate from the retinoblastoma, but I don't think that we can totally say this is not the retinoblastoma. So which means at the end, maybe they need to do like some treatment or get a tissue or inoculations. This is another patient, 7-year-old girl with come to the ophthalmology clinic with a 3-month history of left eye drifting. So this is the image from the article that I want to show you. This is the first time when I start looking on build these lectures together, and I start trying to find a case for this diagnosis, and I could not find any of this diagnosis with path proven in our system. So this is the images from the article. So on the axial T1, you see some area of maybe curvilinear, some lesions along the left lateral group. And then on the T2, that confirmed the lesion that had more like a T2 hypointensity along the left lateral group, and maybe posterior of the lens at the location of the ciliary muscles. On the post-contrast images that show abnormal contrast enhancement and also intense contrast enhancement along the posterior of the lens and the ciliary muscles bilaterally. On the diffusion weighted images, it shows some restricted diffusion of the tissue, enhancing tissue posterior to the lens. So this patient turned out to be intraocular medulloepithelioma. And this case is from the AIRP that published on the radiographic. So this is super rare. It's a case report or like a case series. Second most common of the eye tumor after retinoblastoma. This is a tumor from the ciliary body epithelium. And this is usually happen in the patient in the first decade of life, less than 10 years old, and usually around 5 years old. Unilateral, no sex predominant or no risk factor. This is like a more sporadic. I think the key thing is the location that are posterior to the lens and at the ciliary bodies, muscles that make you think about this diagnosis. This is another patient that we have the 6 years old with the leukocoria. So that we have the imaging, we have the on the left, this is a T2 3D image that you can see maybe some like a subretinal fluid here that are T2 ISO or slightly hyper. And on the inferior aspect of the first image, more inferior of the group is more like is it like a triangular shape that has the apex at the optic disc. On T1, that fluid has a little bit hyper intensity, maybe some hemorrhage or high proteinaceous material, and maybe some enhancing stalk, something here. And on the sagittal image, so these things show you that there is no like a soft tissue behind the lens. So what is your diagnosis? Do you know? So this is a coat disease. So which means for the coat disease, it is a congenital idiopathic retinal telangiectasia that affect development of the vascular of the retina. So that has some weakness of the vessel wall. That's why I have a leakage of the fluid to the subretinal area. That's why we see like a retinal detachment. And those fluid collections can be exudative or high proteinaceous material. It usually happens in the patient less than 10 years old, unilateral. The groups are usually normal and no calcifications. So the first thing is you see the subretinal hemorrhage and also retinal detachment. You need to find if there is underlying mass. And in this patient, we don't see any mass here. So on the imaging findings, you see like a hyperdensity because high proteinaceous material of the fluid, V-shaped retinal detachment, rarely calcification, and normally no extension beyond the groove. So differential diagnosis is still like in the group of retinoblastoma that you need to find any like a mass in that group, and also the PHPV and retinopathy of prematurity. This is another diagnosis of the 1 month old with leukocoria. So when you look on these images, this is a T2 image and T1 post contrast. On this image, you can see the right group is relatively small, right? And also some maybe like a dysplastic appearance of the lens that you cannot see very well, and also like a stalk that connect from the posterior lens to the optic disc. So with this diagnosis, and you don't see any like an underlying mass at all. So with this diagnosis, with a small group deformity and has an enhancing stalk from the posterior lens to the optic disc. So this turned out to be the persistent fetal vessel or PHPV, that enhancing stalk from the posterior lens to the optic disc, that is a persistent fetal vasculature that contain the arteries. So this is one of the congenital malformations that normally that fetal vessel normally develops starting at GA 7 week and then start regression at 20th week, and you should not see anything left over at birth. So if it persists, it's like a coagulate canal that has a fibrous tissue and also the hyaloid artery that cause sometimes see like the triangular morphology as a martini grass, like that one that show contrast enhancement. I think like this is one of the most important thing is, as we know, this is congenital malformation. So this patient usually have like a leukocoria first day of life and has like a deformity, abnormal shape of the group, like a microphthalmia. And on the imagings, no calcification. And you can see like a intraocular hemorrhage or retinal detachment. Okay, so fellows too who want to take this one, newborn with left leukocoria.
Yeah, I can take it. This is Paul.
Thank you, Paul.
So the left globe does look asymmetrically smaller compared to the right side on both the T2 and T1 weighted images. You know, the vitreous body somewhat has this kind of, you know, funnel-shaped martini glass appearance. It makes me concerned that there could be some retinal hemorrhage and detachment. The post-con doesn't, at least to my eye, reveal any underlying mass or lesion. And then the optic nerves look small. So, you know, I may have to stick with the differential here. This could be PHPV or persistent, you know, fetal vascularity, or it could be Coates. I'm not sure if this is a boy or girl, but those would probably be my two leading differentials with this.
Okay, so what do you think
and
about
then,
the optic nerve?
Yeah, so
It's
the
like
optic nerves are small, and there's an absence of the septum pellucidum on the T2 weighted image on the top right and the bottom right. I think I'm just seeing kind of normal posterior pituitary bright spot. I'm not sure what else I'm seeing on that T1 sagittal.
I'm
But
trying to
that
show
makes
you
me
the midline structure on the T1.
Oh,
And you already mentioned that you see the normal posterior pituitary bright spot.
yes. I'm not sure. Maybe the chiasm is just small. Hard to tell. But all the I see. I see it now. Okay, there's a thinning of the corpus callosum, and but midbrain volume cerebellar vermis all looks okay. So far, I'm thinking that this could be also a component of septo-optic dysplasia.
Good job, Paul. That is the correct answer. So besides the persistent fetal vessels in the left globe, that you see the small deformity of the left globe, and also like the martini glass appearance of the fetal vessels over there. So you also see like a optic nerve hypoplasia, bilateral optic nerve hypoplasia. And then you see like an absent septum pellucidum. So I think this patient has two things that happen to her. Is the PHPV or persistent fetal vessels on the left globe, and also the septo-optic dysplasia spectrum. So that's why we need to check. I mean, for the children, for the baby, that we need to do like a brain and orbits together. Good job, Paul. So this is another patient, 2 years old. I have only single images here on the orbits. So on this image, you can see the abnormality is on the left globe that has like a very small left globe, and also like some deformities, and also some internal content that has like some septation inside, layering T2 hypointensity. That could be like a retinal detachment with hemorrhage or intraocular hemorrhage. And then when we look closely on the MRI brain findings, so we see like a diffuse white matter volume loss, has some evacual dilatation of the left lateral and bilateral ventricles, and also some periventricular flare hyperintensity, likely periventricular leukocoria. And on the SWI images, you see some punctate punctate susceptibility artifacts that could be like a microhemorrhages. So if we put this thing together and we look back on the patient history, so this patient is a former preterm 24 weeks, and has the retinopathy of prematurity because there is like some hemorrhage, retinal detachment in the left globe, and also has the findings of the prematurity, including like a white matter volume loss, periventricular leukomalacia, and also microhemorrhages that could be related to reperfusion injury within the white matter. So, so for this one, it's like an abnormal vascular proliferation that occur for the retina of the preterm that result in like a more like a traction or retinal detachment and cause blindness. Usually like a bilateral, asymmetric. You can see like a leukocoria with retinal detachment in the advanced disease. And I think like the key imaging finding is like it's more like a destruction, like a more deformity of the growths. You can have like a retinal hemorrhages, and also like maybe some calcification, like a dystrophic calcification in the late disease process. this is another one, another patient, 7 years old with leukocoria. So I have two images here for you to see. The first one is the axial T1 and the second one is the axial T2 3D. So on the first image, I have this one for you as a reference for the normal layers of the retina, colloid, and sclera. The first thing that you can see here is there is like a maybe focal outpouching at the optic disc. And when you look closely on the T1 that you normally see hyperdense colloid, there's some like a focal disruption of the colloid layers that has maybe like a defect over there. So this patient has a choroboma, optic disc choroboma, which is a congenital defect, failure closure or the choroidal fissure, which can be like a unilateral or bilateral. This patient can present with leukocoria because interruption of the colloidal layer, and it can be isolated finding or associated syndrome like a Charge syndrome. So diagnosis mean age about like a 9 months, but it can be like a happen anytime, like from first month of life or like until like a 19, 20 years old. This is one thing that I want to get your opinion, Dr. Knight, about like the morning glory disc and also choroboma with cyst. That how can we differentiate those two things on the physical examination or endoscopic exam? Because my understanding is like for the morning glory disc, it is like variations of the choroboma that happen in the optic nerve sheath, in the optic disc. So when we have those things in the optic disc, we call like a morning glory disc. And I have two challenging cases for the two fellows. So the first one is at 12 months old with the orbital swelling and leukocoria. Who want to take this one?
I can take it.
Yes. Thank you, Kenneth.
So left image T2, and looks like there's an area of hypointensity along the posterior aspect of the right globe, and kind of some thickening of along the inner layer, maybe along the retina. And then it also looks a little small.
Yes, correct.
The globe. The bottom left image is T1, and it looks a little bit hyper intense on there.
Correct.
The middle image is post contrast and doesn't really look that enhancing. Maybe a little bit, I guess. There's some, but doesn't look like a enhancing mass.
Agreed.
And then on the diffusion and ADC, DWI and ADC, it's quite mild in terms of the hyperintensity on the DWI and hypointensity on ADC. So not super diffusion restriction. I mean, I know like it's like if that like thickening on the posterior retina is like an exudate, that like causes that thickening that can be seen with like Coates disease, but I'm not really sure.
Do you need more help? I have like a more senior images for you.
Sure.
Oops. Did not show. Hold on. Nope. Oh, what happened with my senior images? Hold on.
Yeah, this is like the high resolution T2 and yeah, it looks like there's a regular area of hypointensity on the posterior aspect of the globe. And then T1 it's kind of hyper intense.
Mhm.
And then I don't really know what's going on that right image. Oh, okay. And there's like diffuse enhancement of like
Okay,
the,
first, pay attention in the right group first.
okay.
So what is your answer for the right group? What do you think? Is it like a retinoblastoma? This is a tough one, Kenneth.
For the right globe. Yeah, could be, but I don't know. It doesn't really, it seems more diffuse. I would
Right,
think
right.
mass, it looks less mass-like to me.
Yeah,
Um,
yeah. So I think like you are on the right direction, that you see like a retinal detachment on the right group, and relatively small of the right group, no restricted diffusion at all, and you don't see any enhancing mass. So you already mentioned that this could be like a cord disease, right? Like a exudative in
Yeah,
the
I know it has
retina.
like a thickening of like the posterior aspect of the globe. But I mean, it probably could be something else too.
Yeah, that one. But this is additional finding. So I think like that is the correct answer of the like a cord disease that has like the exudative, like a hypertonious material, subretinal,
Okay.
retinal hemorrhage things, right? But these are another findings. But this is like the cord disease, like the right. Leukocoria is not the presenting symptom on this patient. So actually the main findings that bring the patient to see the doctor is like an abnormal marrow signal intensity with contrast enhancement along the like orbital wall here. If you can see
Yeah.
here, right? And on the
Yeah, I
post-contrast
noticed it on
image.
that like
Yep.
right image. I was like,
Mhm.
oh, something's going
Yeah.
on there.
Yeah, this is like a totally abnormal, something involved in the bone, has like some soft tissue density, involvement of the bone. And if I tell you this patient present with like a raccoon eyes, 12-month-old raccoon eyes.
Is it
So,
like neuroblastoma then?
yes. So this patient has like a metastatic neuroblastoma. And that core disease is like just a coincident findings that when the patient come to see us with like a swelling, and then they did the physical examination and find like leukocoria. Yep. So this is a core disease with neuroblastoma metastasis. And this is the last one for the last fellow who want to take this one.
I guess I'm the last fellow.
Yes. Okay.
The CT, axial and coronal. Looks like the left globe is a little bit smaller. And there's kind of like a fluid attenuation kind of posterior to the globe. I don't know if it's like a big coloboma or some other sort of like cystic structure, kind of like in the posterior globe. There's also kind of like a sort of curvilinear hyperdensity. I don't know if this is like blood products or, yeah.
Okay, so I have more images for you.
Okay, we got some MRs, top left T2 axial, bottom T2 sagittal, and then looks like a post-con T1 fat sat. Seems to be kind of like fluid intensity. Doesn't seem to really have any enhancing component to it. It kind of seems like it's kind of like tugging or something, kind of like in the posterior globe. I'm almost kind of wondering if this is kind of like post-traumatic, but yeah, not entirely sure. There's some sort of like cystic structure kind of posterior to the globe. Doesn't have any enhancement.
Okay. So do you have any like a diagnosis, or just
I
want
guess I
to
was
say?
thinking just kind of like a coloboma, like a really big one.
Yes, that's correct. So because you can see like there is like a deformity of the left globe, and also maybe some dysplastic of the lens, right? And also like the large cystic lesion, that when you look closely on the T2 3D images, there is like maybe some gap over there that connect to the posterior globe that show like that intraconal cystic lesion. So this is a coloboma with cyst. Right.
Okay.
And on the T2 3D image, that can show you that a cystic lesion that takes place in the intracorneal space and also has a connection with the posterior group, things that has like the same content over there. Yep. And on the post contrast, we don't see any contrast enhancement within that lesion. So this is a choroboma with cyst. Yep.
Okay.
Yep. Good job. So in summary, for the pediatric leukocoria, the teaching point that I want to give it to you today is when you see that things, when you see that indications, you need to think about retinoblastoma until proof otherwise. We need to do like a MRI brain and orbits to checking for any like a metastasis, intracranial extension, or any other associated findings. Highly recommend to get the high resolution T2 3D with axial and coronary formats because there is many times that patient present with like a only right leukocoria or left leukocoria, and we find additional lesions on the contralateral side, and the ophthalmologist can like look back under sedation and find that lesions. And also highly recommend to get the DWI and ADC to see if there is any restricted diffusion in that abnormality or not. So check on the group size, big or small, right? If you have like a normal or a little bit larger size, it can be like a group of the retinoblastoma or cord disease. For the smaller deform, it can be like a retinopathy of prematurity or persistent PHPV or PFV, persistent fetal vessels. And then you check for any like a retinal detachment or hemorrhage, and check for any underlying mass. When you see mass, that is retinoblastoma. This is a summary table that I used when I was a fellow to remember those things. So retinoblastoma has a mass lesions, 95% calcification, and also show restricted diffusion. And in terms of the imaging sequence things, so we know that we use T1 for the hemorrhage, hypertenacious material, T2 for like a probe site, GRE or SWI for hemorrhage and calcification, and we use the DWI for like a tumor grading. High resolution T2 is a must to have for increased sensitivity to detect additional lesions. Reduced field or small field of view, SWI and DWI help you with the image quality and sensitivity to detect tumor. And I just found, after like reading like multiple articles and put things together, I found this may be very helpful. At least you have like something in your mind on the age group when you see like a leukocoria in children. So for the PHPV or persistent fetal vessels thing, is this a congenital stuff that it could be like a leukocoria at birth, right? So you should see those things during the first year of age. Retinoblastoma is the disease that exclusively for children, so normally like less than 5 years old, but majority usually happen in the first or 2 years of age. And also retinopathy of prematurity, that is like a sequelae of preterm, part of the sequelae of preterm and post-treatment from the oxygen supplements. So you usually see those things like in the maybe like first 5 years of age. And then for the meduloepithelioma, that usually maybe like after 5 to 10 years of age, with the peak or like a median age at 5 to 6 year old. Cord disease may be the same thing, like less than 10 years old, and majority that we see the patient usually like 6 to 9 years old, and choroboma you can see it at any age. So I think that's it for me. Thank you so much. Any questions? Happy to answer any questions that you have.
If there aren't any immediate questions, I can pull up a couple pictures that I found regarding your question on optic nerve coloboma and morning glory. Is that okay?
Yes, please.
All right. Can you see this one?
Yes.
So this is a classic picture of an isolated optic nerve coloboma. So that it's usually inferonasal, but can be inferotemporal. It's almost always inferiorly on the optic nerve. So the top half of the optic nerve looks pretty normal, but then you have obvious abnormal tissue here, pigmentation. And if you have a three-dimensional view, this is excavated and kind of conical, similar to the morning glory, but it's very clearly just half or a portion of the optic nerve. And then same thing here, very clearly abnormal. It's excavated. It almost seems like the disc is split in two here. You can see the top half of the optic nerve here looks pretty healthy and normal. And then there's this abnormal closure here with both hypo and hyperpigmented, and then almost the second half of the nerve here coming off and the blood vessels going in that direction. But in stark contrast, the morning glory optic nerve, usually the optic nerve is pretty well rounded. It's you can tell where the nerve ends. And then the deep excavation is right in the center. This thing just drops off like a canyon in here, and then the increased number of straight branching arteries and veins, and then the pigmentation changes around that nerve. So again, this almost has a half of a normal nerve, and then some other funny business, and then same thing here, almost half of a normal nerve, and some abnormal nerve. Whereas over here, the tissue is nice and round and well circumscribed, and the deep excavation is smack dab in the center, and then all these straight branching vessels. So this one I would classify as the morning glory nerve. And we would have to do kind of MRA imaging to look for moya and abnormal cerebral vascular anomalies. And then, here I think, unless there's a large cystic component or proptosis or something else going on, you may or may not image kiddos with coloboma.
I see. So which means like you can give the diagnosis based on the fundoscopic exam, and
usually.
You just order, and you just order.
Usually.
MRI.
I think if it's kind of there are a few that are not as clear as those, and I think whenever there's diagnostic uncertainty, then I would say optic nerve coloboma versus morning glory nerve. Look for moya or cerebral vascular anomalies.
So you're looking for like any other associated finding?
And then the Facies syndrome, like if there's other things, cardiac and facial hemangiomas, then obviously we're looking for posterior fossa malformations and just other arterial malformations. So MRI, brain and orbits with and without, and then your MRA to look for the other things.
That's good. Thank you so much for clarifications. Any questions from the audience from IU? Hey Taylor, I have one more questions for the. So right now with the high resolution T2 3D image, sometimes we see like the tiny pit or defect at the optic disc, and we call like a retinal pit. Is it like a clinically significant for you?
In what condition?
It just maybe like a random, it's not a real leukocoria. It's just maybe like some random like a indication or something, and we start seeing like the tiny defect at the optic disc, which I think is maybe like related to the high resolution images that we have right now. So sometimes we comment on those things as like a retinal pit, PIT.
And it's at the optic nerve head, and it's not protruding into the globe. It's actually the reverse direction.
Yes. So is it like any clinical significance for you?
Yeah, that's a good question. It'd be tough without knowing what their nerve structure looks like. Sometimes in our highly myopic kids or kids that are kind of deemed a glaucoma suspect, they can have a large cup to disc ratio, and sometimes their nerves have a morphology where it's just there is a really deep cup there. And so I'm wondering if with your 0.5 millimeter cuts, if you are picking up on that, and then maybe you're getting an increased cup to disc ratio on your imaging, and that might prompt a couple referrals to us. But I'm wondering if it it could be just a normal variant.
So that's why like sometimes I don't mention those things because I don't think it's I think it's because of like the imaging resolution that we have. So that's why we see things better. But so my question to you, like, should we mention those things or should we just ignore those things?
Yeah, it's hard to say if they
yeah.
haven't had a normal, or a baseline eye exam. I don't know, might not hurt, and then maybe we pick up on what you're seeing, and if it's a normal variant for us, then no worries. But if we see anything abnormal on examination, maybe that does change the referral pattern. And so I think refer for now, and we'll take a look at them, and if it's normal, then we'll let you know.
Okay, sure, that sounds good to me. Seem like we don't have. Do you guys have any questions, the audience from IU? If not, thank you so much, Taylor, for giving us an excellent lectures and have like a clinical correlations and clarify us like what we need to do and what you need to know from us. So thank you so much for your lectures today. And I also have the evaluation sent in the chat box. So please, the people who attend these lectures, please complete the evaluation so we know what we can do better in this lecture, or what do you need to know more from the clinicians. And for the people in Thailand, we're gonna send out an evaluation to you. So please complete the evaluation by Friday over the weekends on the September 3, and you will get the Thai CME credit. So thank you so much, everyone. Taylor, you have any last word to say? Anything before we?
Yeah, I wanted to thank you again for having me, and all of the images that you presented were fantastic. I think we tried to drive home the thing that we're always most concerned about is retinoblastoma, and that's the thing that we never want to miss. I think most common is cataract, but most concerning, most worrisome is retinoblastoma. And the imaging that you presented, the MRA is crucial in these kiddos, as our treatment modalities have changed from systemic chemotherapy to intraarterial chemotherapy, especially in unilateral cases, or cases that are not responsive. It's really pretty incredible what we can do to treat this, to try to save the eye, and then sometimes vision in these kids. And but life always comes first. That's the treatment paradigm. It's cancer. It's not something to mess around with. So thank you again for having me. It was a pleasure. Again, happy to take any questions or feedback on how to make things better in the future.
Thank you. Thank you so much, everyone. See you next time. Bye-bye.
Thank you.
Thanks so much.